I'm Dr. Asim Javed and I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning of image interpretation in coronary intravascular ultrasound. This is the first talk of this series, when and why to do IVUS. What's the clinical evidence that we have for using IVUS? So let's start off with a case. Now, this is a 66-year-old gentleman. He had occasional episodes of retrosternal chest heaviness at rest only. His ETT was borderline positive for ischemia, and on myocardial perfusion scan, there was 8% ischemia burden in the LAD territory. With ongoing symptoms, we decided to go for an angiogram. The right coronary artery was dominant and normal. The left coronary artery, you can see that there is, by and large, it looks good. But in this caudal view, there is some minor disease in this proximal segment, but nothing significant. On the cranial view, you can see again that in the mid LAD, just after the diagonal takes off, you can see there is slight irregularity or minor disease you can see here. But there is nothing much really. If you see this magnified view, there is minor disease here in the proximal LAD, and you can say that there is minor disease between these two diagonals, but nothing more than that. So I put this patient on medical treatment, high dose statins, with a target to reduce the LDL and all. But 3 months later, I got a phone call, and the gentleman reported to a private hospital with anterior STEMI. And the mid LAD, right between these two diagonals where we thought there was minor disease, is where he blocked his LAD. So the interventional cardiologist there very nicely put in a drug-eluting stent. Unfortunately, there was a perforation at the distal stent edge, which they very nicely covered with another drug-eluting stent. They did not put a covered stent. This drug-eluting stent did the trick, and the perforation sealed. Now the question is, why did this gentleman have myocardial infarction? Well, we do know that mild to moderate disease can very much cause myocardial infarction. But why is that so? So one of the clear limitations of angiography is that it grossly underestimates the presence and magnitude of disease. Now, Dr. Robert was amongst the first ones who published a lot of work on this issue. He studied coronary bypass patients who died within a month of surgery and underwent autopsy, and compared the angio findings to postmortem findings. On the right, you can see angio appearance of a right coronary artery there, and look at the extensive atherosclerotic disease on postmortem, which was grossly underestimated on angio. And furthermore, angio also does not tell you about the plaque composition. So you can see how heavily diseased this right coronary is, which you couldn't appreciate on the angiogram. So why does that happen? But before that, look at this LAD. You can see that this LAD grossly or angiographically looks normal. But if you look at all these four areas which I have marked with A, B, C, D, we will discuss this later on, but you can see some plaque at A level. You can see quite an eccentric plaque here at level C. There's a concentric plaque here at level B and then at level D. So this is a diffusely diseased artery. This is not a normal artery. It looks angiographically normal. But how come the disease is not showing up on the angiogram and it's only visible in the IVUS? The reason is that there is a concept of coronary remodeling hypothesis. That's a normal vessel. So when the plaque starts developing in the intima, this is the intimal layer and you can see the plaque developing in it. So the artery tries to compensate by expanding outwards, and the vessel tries that the lumen should not be compromised with presence of this plaque. So the plaque keeps increasing and the artery keeps on expanding towards the outer side, but it does not compromise the lumen till the time the plaque extends to a level where the artery cannot expand any further, and then this plaque starts pushing the intima towards the inner side and the lumen gets compromised, and that's the time on angiogram, because the angiogram is a luminogram. So you see the lumen compromise. That's when you have a severe coronary artery disease. The positive remodeling has taken place. It cannot expand any further, and now the lumen is being compromised. Now, there is a discrepancy between the angiogram and IVUS. You can see here the left main stem looks pretty normal. I don't see any significant disease there. But if you look at the IVUS of this left main stem, the MLA is 4.6 millimeter square. And we do know that on IVUS, if the MLA in the left main stem is less than 6, that is a significant disease. On the angiogram here, you can see seems to be a significant osteal disease on angiogram. But when you do the IVUS study, the MLA is 8.6 millimeter square. That's because the takeoff angle is such that it gives you the false impression of a significant disease in the left main stem ostium. In actual fact, the MLA is 8.6 millimeter square. There is nothing significant in this left main. So Gary Mintz has done huge work on IVUS. And in one of his publications, he showed that in 884 native coronary arteries, the plaque burden in the angiographically normal reference segment was 51%. So these are angiographically normal appearing vessels, but the plaque burden was 51%. And then Antonio Colombo also demonstrated that after routine more than 16 ATM final stent dilatation, so most of us feel very comfortable that we've dilated the stent to 16 ATM, so now the stent is well deployed, no issues. So what he demonstrated was that after more than 16 ATM stent dilatation, 33% of these lesions required further dilatations following IVUS. So when you do the IVUS, you realize that the stent is either not well expanded or it's not well opposed, and you need to further post-dilate the stent. Now, this is a clinical follow-up in 357 intermediate lesions in 300 patients with deferred intervention after IVUS imaging. So these are the cases where intervention was deferred, the lesions were intermediate. And the only independent predictor of death MI TLR was IVUS MLA. So the smaller the IVUS MLA, the higher the chances of MACE. 50-year-old gentleman came in with anterior myocardial infarction. He was late for thrombolysis, had an ejection fraction of 35%, and later on his myocardial perfusion scan showed by and large viable myocardium, and that's his angiogram, and anybody is welcome to comment on it. So in my opinion, this patient had critical osteal dominant circumflex disease, but his myocardial infarction was anterior. So what I could also appreciate was that there is some sort of a moderate to intermediate disease in the ostium of the LAD. That was my opinion initially. And there is a healed or an organized thrombus seen in mid to distal LAD. So again, looking at different views, that's the caudal views and that's the cranial views. So how would you proceed with this patient? Now, looking at the LV angiogram and the right coronary artery. So what I wanted to figure out was the functional significance of the LAD disease. So IVUS does not give you that. IVUS gives you an anatomical appearance, and what you need here is an FFR. So we went ahead with the FFR. We did FFR of the dominant circumflex first, and then we went on to do the FFR of the LAD. Now for the dominant circumflex, the IFR came out to be 0.80, which is less than 0.89, so that is significant. We do not need to perform FFR now, but academically we do things here with our fellows, so we went on to show them the FFR, and with the adenosine the FFR came out to be 0.65 for the dominant circ. So that's again highly significant FFR, and that was expected. In the LED, however, the IFR was 0.85, which is again significant. And when we did the FFR, it reconfirmed that it was a functionally significant disease. FFR was 0.75. Just to show you a comparison of the two, if you look at this figure, this is the dominant circumflex FFR, and you can see a sharp rise in the gradient where the yellow line goes and meets the red line. Now this sharp rise indicates a sharp step up in the pressure gradient when you are pulling back the FFR wire, and that shows a focal critical stenosis as seen in the ostium of the dominant circumflex. But on the other hand, in the LAD, you see a gradual diffuse line going up and meeting the red line. So this is a gradual increase in the step up, and this is a diffuse disease in the LAD that you see here. So this is not to confuse you. This we will discuss later on in another talk. But what we wanted to show now to our fellows was that there must be a significant plaque in the LAD, that the FFR is so significant, because the LAD did not appear that bad. So we did an IVUS. If you look at the IVUS of the circumflex, you can see that there is an eccentric plaque in the ostium of the circumflex, and the MLA came out to be 2.9 millimeter square, which is less than 4 millimeter square, and as per the guidelines, even this IVUS criteria is met for significance. Now, when you come to the LAD and you do the pullback with the IVUS, you see that here you can see a concentric plaque coming up, and then it keeps going up, and where it started is exactly where this IVUS tip is. If you see the IVUS tip here in the LAD where the large septal is coming off, this is where this concentric plaque started, and then at the ostium of the LAD, the MLA is 3.5 millimeter square. It's an eccentric plaque here, and the MLA is 3.5 millimeter square, and that's again highly significant. So what you have here now is a diffuse disease in the LAD starting from the ostium going right up to the mid segment, which you can see even here angiographically. Now that you look carefully, there's a large septal coming off, and distal to that you can see that the diameter of LAD is much bigger than the diameter of the LAD in the proximal to mid segment just before before this large septal comes off. So there is diffuse plaque all the way from here to the ostium of the LAD, and a significant osteal critical disease in this dominant circumflex. So now our plan changed, and we decided to go ahead for this patient with CABG surgery. What we see with IVUS is not only much more disease than we ever expected, but we find with stenting that we often miss incomplete apposition, incomplete expansion, and edge dissection. Look at this left main stem. Angiographically, it looks acceptable, but IVUS shows grossly underexpanded and malapposed stent. Now, next picture shows a slightly improved angiographic result after post-dilatation, but IVUS shows a very acceptable stent result. So, angiography is actually inferior to direct imaging technique. Now, if you look at the stent cross-sectional areas, you can see here in this graph that the restenosis is directly linked with the stent cross-sectional area at the end. And if it's below 8 millimeter square, the stent cross-sectional area, then the chances of instant restenosis keep going high as the CSA goes small. So that's why if you see here that anything below 8 has high ISR relation, and from the formula of finding cross-sectional area, you can see that with the 3 millimeter stent you can achieve a cross-sectional area of 7.1 millimeter square, which is still below 8. That's why for the bare metal stents 3.5 and more is the recommendation rather than 3 millimeter or less stents. That's because this study was done in the bare metal stent era, and you can see that this result shows that why we've got the recommendation of 3.5 millimeter or more for the bare metal stent. Now, there are a lot of studies that have shown that small stent cross-sectional area and edge problems correlate directly with early thrombosis and restenosis. Some of those studies are mentioned here. And this is a meta-analysis of 11 studies including 20,000 patients, which showed that compared with angiographic guidance, IVUS guided DES implantation was associated with a reduced incidence of death, stent thrombosis, and MACE. Now, this is ultimate trial, and the conclusion of this trial was that IVUS guided DES implantation significantly improved clinical outcome in all comers, mainly due to significant reduction of clinically driven TLR or definite stent thrombosis. Almost 1,500 patients were enrolled in this trial. I would like to draw your attention to ADAPT DES trial done by the Columbia group, including Greg Stone and Roxana Mehran, looking at dual antiplatelet therapy in drug-eluting stents. Now, there is a subgroup study looking at IVUS guided versus angio guided procedures. So there were over 3,000 patients in the IVUS guided procedure arm and 5,000 with angio guidance alone. In the results, what you can see here is that in 75% of the cases or 75% of the times with IVUS guidance, the procedure had to get something additional done to optimize the result. It could be because of the stent under expansion, malapposition, or edge dissection, which would require either an additional stent or a higher pressure or large size post-dilatation balloon. Now, with ADAPT DES, what we can conclude is that IVUS guidance changed the procedure more than 75% cases with longer appropriately sized stents, and IVUS guidance improved clinical outcomes by 33% reduction in myocardial infarction, 50% reduction in stent thrombosis, and 38% reduction in target vessel revascularization. So benefits of IVUS are consistent across the randomized controlled trials as seen here. The target vessel failure, which is defined by cardiac death, target vessel myocardial infarction, and target vessel revascularization, and in all of these trials you can see that IVUS does much better as compared to angiography alone. The same benefits are consistently shown across in the acute coronary syndrome patients as well. Now, IVUS ACS, this is a randomized controlled trial involving around 3,505 patients, and this was the first large RCT looking at ACS patients with 40% unstable angina, 31% NSTEMI, and 28% STEMI patients. And again, the target vessel failure at 1 year was much less in the IVUS arm as compared to the angiographic guided PCI arm. Now, this is a meta-analysis of 20 randomized controlled trials involving 12,428 patients who underwent IVUS guided intervention versus angio guided intervention, and this involves trials up to year 2023, and it has shown consistently favoring IVUS imaging over angio alone. So, compared with angiography in this meta-analysis, the IVUS guided imaging PCI, the primary endpoint target lesion failure was 31% reduction in the IVUS guided arm, and this was mainly driven by 46% reduction in cardiac death, 20% reduction in target vessel MI, and 29% reduction in target lesion revascularization. And in terms of secondary endpoints, IVUS led to 52% reduction in stent thrombosis, 25% reduction in all-cause death, 18% reduction in all-cause MIs. And then the reduction in long-term mortality with IVUS also shown. Premier US nationwide database 2004 to 2019 has shown that IVUS guided PCI reduced mortality at 1 year and up to 10 years consistently in more than 2.3 million patients. So based on all of this data, now the 2024 ESC guidelines have been upgraded, and now IVUS guided PCI is a class 1A indication for anatomically complex lesions, in particular left main stem, true bifurcations, and long lesions. 2023 SC guidelines have already given IVUS guided PCI a class 2A indication for acute coronary syndrome. All of these guidelines that have been upgraded are now backed up by several clinical studies in the recent years, such as the Renovate Complex PCI for the complex lesions, IVUS XPL for the long lesions, and October trial for the true bifurcations. So this guideline update and the strong clinical evidence reaffirm that IVUS imaging is safer, more effective, and better for the guidance of PCI compared to angio guidance alone. 34-year-old gentleman who was a STEMI late presentation but had ongoing angina and dynamic ST changes, and this is the angiogram. And I think you can all appreciate that there's a critical disease with slight haziness in the proximal LAD, and the same you can see on the cranial view. So the next question would be, what stent size and NC balloon size would you like to use? So here, in my opinion, this was a 3.5 to 4 millimeter vessel. So I probably would put in a 3.5 millimeter stent and then post-dilate it with a 4 millimeter NC balloon. Keeping his age in mind and in presence of interventional fellows, we decided to go ahead and do an IVUS run just to see that this is not SCAD. So that's the IVUS run. So what you see here is heavy plaque with overlying thrombus in proximal LAD, and the LAD ostium has a diameter of 5 millimeter. So if I give you still images right at this point, it's unbelievable that this is a 5 millimeter vessel. You can see here, this is a 5 millimeter vessel. You count from dot to dot, that's 1 millimeter, then 2, 3, 4, and 5. So that is 5 millimeter vessel here. And then at the distal landing zone, it's a 4 millimeter vessel LAD, and that's the thrombus that could have been seen on the IVUS run. So we decided to go ahead with the 4 millimeter stent. So this is a 4 by 18 millimeter drug eluting stent. So angiographically, the result looks pretty pleasing. Stent under expansion in proximal part from ostium of LAD till origin of diagonal. That's what was seen here. And the LAD stent beyond the origin of diagonal, that looked okay. So now if you look at this here, you can see that this is not only malopose but under expanded as well, and needed post dilatation. So looking at the size of the ostial LAD, a 5 by 8 millimeter NC track balloon was taken to post dilate the stent in the ostial region. So that's the final result. And if you see the IVUS, so you can see here that angiographically result looks pretty good even at the first time and the second time. But then if you look at the IVUS runs after the first stent deployment, you can see that on IVUS it's a very malopposed and unexpanded stent. Although angiographically looks pretty good, but angiographically this is after IVUS, and you can now see the difference how well opposed and well expanded this stent is. Now we have talked about vessel architecture, but what about plaque composition? We know that lipid-rich plaques lead to more rapid plaque progression, plaque vulnerability, distal embolization during PCI, subacute and late stent thrombosis, and edge restenosis. Then uncovered lipid core plaques are associated with subacute and late stent thrombosis and edge restenosis. We may be able to detect these vulnerable plaques prospectively, as Greg Stone showed in Prospect trial using IVUS virtual histology. In ACS patients where culprit lesions were stented, he did multi-vessel IVUS virtual histology imaging. The biggest, bulkiest plaques with most lipid core and smallest MLA, that's thin cap fibroathyroma plus plaque burden of more than 70% plus MLA of less than 4 millimeter, less than equal to 4 millimeter square, were having the highest event rate, almost 20% MACE rate over 3 years. These plaques were pretty prevalent, almost 15% had a plaque like this. So these are the main criteria that we need to remember, which represent a vulnerable plaque: thin cap fibroathyroma, plaque burden more than equal to 70%, plus MLA less than equal to 4 millimeter square. Now, this is just an example of different things that you can see on IVUS. You can have a normal looking IVUS, you can have a concentric plaque which is all around, you can have an eccentric plaque which is towards one side. There can be soft plaque, fibrotic plaque, and calcific plaque. So these things, this is just to give you an example of what all IVUS can show you, but we will discuss them in the individual talks. Can the plaque morphology help in treatment strategy? Yes, if you know that there is a soft fatty plaque, it's much easier to optimize your stent and you can do balloon pre-dilatation and get away with it. But if it's a fibrotic plaque, there will be tendency for slipping of the balloon. There can be plaque shift. So in order to avoid these, cutting balloon can be a good option. And if it's a calcific plaque, then you probably need a rotational atherectomy. Again, different pathologies in the morphology that you can see on IVUS. You can have dissection, you can have plaque rupture, thrombus, hematoma, there can be a false lumen. So all of these we will see subsequently in the coming talks. Now, this is just to give you an example. This is a right coronary artery mid RCLE, and you can see this is quite tight. If you do the IVUS, you can see that this IVUS image is representing the reference, proximal reference and the distal reference, and the distal reference was taken as 3 millimeter. This is the distal reference, so the landing zones are neat, clean, but right at where the lesion is, you can see that it's pretty tight, snug fitting around the IVUS catheter. It's quite a tight lesion. So pre-dilatation was done with the 2.5 and 3 millimeter NC balloons. And after pre-dilatation, this was the IVUS result. So you can see that the non-calcific side actually gives way. You actually, the cut or the cleave is in the non-calcific side, so the vessel expands. So now the vessel is ready for angioplasty, stent is put in. Angiographically, it's a very nice result. Proximal reference segment, the stent is very well opposed, fully expanded. At the distal reference segment, the stent is well expanded, well opposed. But right where the lesion was, angiographically, it looks perfect and you can stop. But if you look at the IVUS, it's not well expanded here. And if you look at the MLA, MSA, the CSA of the stent, the cross-sectional area is 3.7 millimeter square. And we know that that will lead to a lot of ISR. So this led us to then use a 2.5 millimeter OPNC balloon at 40 atm pressure, and then it was followed by 3 millimeter non-compliant balloon to optimize the result. So with OPNC, my policy always is that I don't go 1-to-1 size with OPNC. I always undersize my OPNC, because the risk is that if you go 1-to-1, the calcium on the outer side can actually cause a perforation or vessel rupture. The purpose is of using OPNC, the criteria is that you need to create cleaves or break lines on the inner side in the intima, and once that happens, then you can use a non-compliant balloon of 1-to-1 size and expand the vessel. So, but at 40 atm pressures, I don't want 1-to-1 size OPNC. This is my personal practice. I tend to undersize the OPNC. So that there's a lot of data that is shown that IVUS is much better than angio alone, and there are certain studies that show that ultimately IVUS catheter turns out to be cheaper as well in terms of preventing stent thrombosis, the restenosis, the repeat interventions and all of that stuff. So it ultimately tends to be cheaper. Benefits of IVUS, well, when it comes to physiological significance, that's an area where FFR gets an edge. But IVUS, certain criteria, there is correlation between FFR and MLAs that we see on the IVUS. But other than that, all the morphology, the stent optimization, the stent planning, everything is based on IVUS. So we can see that IVUS helps us to measure the exact distance of the lesion, the length. So you can see the length of the stent. It defines the morphology of the plaque, whether it is lipidic, it's fibrotic or calcific. And then you can also determine the diameter of the disease, what's the size of the stent that you need. You look at the stent edges, look for geographical miss, you look for edge dissections, you look for stent apposition and stent expansion in order to optimize your stent result. So you can say that coronary angiography has limitations, but with IVUS, you see the exact extent and type of disease. Therefore, you plan how to deal with it. Once you've dealt with it, then you confirm if the vascular bed is well prepared. Is the lesion fully modified now and ready for the stent? And then when you stent, the IVUS helps you confirm optimal result for that stent. So you can see that in pre-PCI planning, IVUS use leads to a change in treatment plan for more than 74% of patients based on what you see on the IVUS. So you change your strategy dependent on the IVUS. Then once you've implanted the stent, you can further optimize the stent based on your IVUS in more than 30% of the lesions where you had already thought that you've done your best, but with IVUS you further optimized your stent in 30% of the patients. Using the IVUS versus using angiography alone yields lower target vessel failure outcomes both in chronic and acute patients, if you see here. And then it is more cost effective as compared to the angiography alone over a patient's lifetime. Now this is a case, very famous case, which was shown in TCT few years back, where in USA this was ostial left main disease for which CABG was done, but the patient came back with occlusion of the graft. Second time re-angio and then CABG was done, and again the patient came back with the same symptoms, and again on restudy the grafts were down. So this time somebody decided to do an IVUS for this patient, and on IVUS the MLA of the left main stem was 11.9 millimeter square. There was no significant disease in the left main stem, and that's why the grafts did not work. It was just the angle of takeoff of the left main that gave the false impression, and superadded spasm that it gave the impression of ostial critical left main stem disease. So twice the patient underwent CABG. So this is a 37-year-old gentleman, and you can see significant disease in the LAD. It's a proximal disease that you can see here, and on IVUS you can see there is heavy plaque. You can see this all around. It's all heavily diseased LAD actually. So we started the stent from the ostium and went on to the mid LAD. It's a 3.5 by 38 millimeter drug-eluting stent, and that's the stent. Looks like excellent result. We still went on with a 4 by 20 millimeter NC balloon at 16 ATM pressures because we've already done the IVUS. We know the sizing, and this is the post dilatation result. It looks great, but on caudal view, if you notice carefully, there is some shelf-like, there is some haziness at the proximal stent edge, which you can see in this view. There is a tongue-like projection hanging from the top side right here, just proximal to the stent edge. So what is this? Is this dissection? Is it thrombus? What is it? Should we put in another stent and cover this? Should we go across into the left main stem? Well, we've got the IVUS open with us. So we did an IVUS run. And what the IVUS showed us was that there was a plaque prolapse. The stent was well expanded, the stent was well opposed, there was no stent edge dissection, and at the tightest spot in the ostial LAD, the stent MSA, the stent CSA was 9.6 millimeter square, which was good enough. But there was this protrusion of a soft plaque, which was probably as a result of cheese cutting effect of the non-compliant balloon at high pressures. Anyways, after seeing this, we decided to keep the patient on agrastat infusion for next few hours and did not put in another stent. So this is a 45-year-old gentleman. He had drug-eluting stents implanted in LED and circumflex about 5 years ago, and now he presented with angina CCS class 3. So the right coronary artery is dominant, looks okay. In the circumflex, if you see, there is, on the caudal view, there is mild distal disease in the left main stem. Then there is an ostial LED stent, osteo-proximal, in fact, going to the mid segment. And there is a good sized diagonal that is jailed behind the stent. Then there is some significant disease in osteoproximal course of the circumflex, and there is critical ISR in the circumflex stent here. So if we go to the further views, again caudal view, the ostium looks significant, and then there is ISR critical here. The same disease as we described. This is the critical diagonal that you can see here. That's quite a significant diagonal with ostial pinch, and that is the LED ISR that you can see in this view. You can see that. So what else? Okay, we've got more cranial views, and you can see that in the cranial view, the distal left main stem seems a little more than what you saw in the caudal view. That means there is probably eccentric plaque, which is not going to be visible in the same way from all directions. There is going to be one or two views in which it's going to turn out to be more significant than the other views. So with this disease there, we just wanted to be sure about the distal left main stem. So we decided that in the LED left main, we will do an IFR and see if this LED is flow limiting or not. We did the IFR and it turned out to be 0.84, which meant it was critical. It was flow limiting. So then we thought, academically, let's look at the left main stem and see how significant the left main stem is. And the other question I had in my mind was that, is this LED ostial stent actually pinching upon the circumflex ostium, or is the ostium clear of this stent? So IVUS could tell us that relationship. So we went on to do an IVUS from the circumflex side first, and that's the IVUS run. And what it showed was that the proximal circumflex had a very eccentric plaque. That's the eccentric plaque because it's seen on one side. And then as we moved towards the ostium, what we could see was that ostium of the circumflex was pretty significant. There's an eccentric plaque there as well. But at the same time, at 12 o'clock, you can see the LED stent coming on top of it. And the more you pull from the ostium of the circumflex and come towards the left main, what you actually see is that the LED stent is extending into the distal left main stem, and that's the only space left for the circumflex. So the stent is actually not right at the ostium of LED, it's actually slightly into the distal left main, and it is impinging upon the circumflex ostium, and this is a slit-like space left for the circumflex ostium from which the flow is going. So next we did IVUS on the LED side, and there you can see that's the LED, that's the circumflex that's visible here. And then in the left main stem, at the distal left main stem, the MLA was 5.5 millimeters square, which we know is significant. And this is again eccentric plaque that you can see here. It's on mostly on one side, but it's a significant disease there. So now you can see that this patient has significant disease in the mid LED stent, distal left main stem. That's quite a significant diagonal which has a very critical ostial disease. There is a significant critical ostial circumflex disease followed by significant disease in the proximal segment, and then critical ISR in the OM. So this patient was then advised cabbage. So IVUS is very safe. spasm in 2.9%. So it's recommended that you give nitrates before doing an IVUS study, and that spasm issue is gone. Acute complications, major complications, I think it's very rare to see anything with it. What you must not do is push the IVUS catheter into the critical lesion if it's not going in. If it's not going in, it's not going in. Then you need to pre-dilate the lesion, and then you can do the sizing and everything with the IVUS. But don't force it into the lesion if it's very critical and not allowing IVUS. So the benefits of IVUS are in all three stages for diagnosis, guidance, and prognosis. So pre-procedural strategy, you can decide, you can look at the length required, the size of the vessel to stent, and it can guide you to look at geographical miss, stent expansion, malapposition, any dissection, any thrombus, and then you can also identify vulnerable plaques that you are going to leave behind. So in the non-treated lesions, if you do the IVUS, you can identify vulnerable plaques, and if required, you can treat them early on. So for me personally, I would say that IVUS indications include left main stem evaluation. It's a must. Complex PCI, like diffuse disease, it helps you where to land the stent and what size to use. Bifurcation disease, CTO PCI, you can identify the proximal cap, you can confirm the true lumen, what is the size required, the result optimization with multiple overlapping stents. Then I think it's very important to do IVUS for all stent failures. Whether it is stent thrombosis or ISR, you need to know why the stent failed and how to manage it now. Would post dilatation be enough, or you need to restent the stent because there's a stent fracture there leading to this ISR. So then post PCI complications can be avoided by looking at edge dissections if there are any. Then IVUS is very helpful for unique situations like SCAD, you can identify that, and then in high bleeding risk patients. Why? Because you want to make sure that you've got a perfect result of your stent in high bleeding risk patients. If the stent is malopposed, you know it's going to be difficult to endothelialize that stent, whereas you may need to stop the antiplatelet at any point in time. So you need to do an IVUS, make sure the stent is well expanded, well opposed, so that you know that it's going to endothelialize within the next few months, and then you can stop antiplatelets where required and as required.